Good afternoon. I'm Dr. Swami Iyer. I'm at the IACA booth here with Dr. Srinivasan Sanikommu, who is an MDS fellow with Yaroslav Masievsky at the Cleveland Clinic. He has a very interesting abstract that he presented in large granular lymphocyte lymphoma. So, Srinivas, tell me a little bit more about your interesting presentation.
So, as you know, large granular lymphocytic leukemia is a very rare condition. It is usually associated with autoimmune conditions like rheumatoid arthritis, and most of the times they don't require treatment, but sometimes at least half of the patients require treatment for cytopenias like neutropenia and anemia. So, but being a rare disease, there is not many randomized trials to predict the response to the treatment, and also most commonly applied treatments are methotrexate, cyclosporin and cyclophosphamide, commonly used medications. So we have a large cohort of patients, almost 190 patients over a period of 15 years.
That's a big subset.
Yes. Actually, one of the largest cohort that was published so far is a French cohort, and it involved 231 patients from 40 different institutions.
Wow.
Here we have
Single institution experience. That's fantastic.
The problem with being from a different multi-institutions is there is inherent variability in terms of making diagnosis and applying treatments. So here we have an opportunity to identify exactly what is the appropriate treatment for these patients. Being a rare disease, doing a randomized control trial to identify the treatment responses is difficult, as we know from a recently published study by Dr. Lofgren. Is a phase 2 study involving 50 patients, and it took almost 7-8 years to recruit that number of patients. So here we have an opportunity to find out what is the treatment responses in our treatment patient cohort.
So you studied these patients over a period of many years, and obviously you have archived samples that Dr. Masievsky is able to do the next-gen sequencing. Okay?
Yes.
Yeah.
So we, as from 2000 to 2015, over a period of 15 years, we had a sample of 190 patients, and they are all well annotated, and we have all the follow-up and follow-up samples. So we did a STAT3 mutational status on them, and even going back and also looking at their mutational burden on the serial samples.
Okay, excellent. And so what did you find so far?
So far,
in terms of your patient characteristics and also.
So out of 190 patients, we had almost 88% are T cell large granular lymphocytic leukemia, and almost 11% are natural killer cell lymphocytosis, and we have overall follow-up of around 36 months on these patients, median follow-up. And we had in our treatment cohort 47% had anemia and 50% had neutropenia, and our median large granular lymphocyte count was 1700, and almost 23% of patients had autoimmune conditions, out of which 14% had rheumatoid arthritis.
Excellent. And you looked at the mutation status. So
And 37% of patients had STAT3 mutations out of these patients. So we try to identify the treatment responses in these patients, whether STAT3 mutational status is going to predict the treatment response to the commonly applied therapies, namely methotrexate, cyclosporin and cyclophosphamide. We identified that patients with STAT3 mutational status had better response to cyclophosphamide, 60% compared to 46% in wild type STAT3. However, it is not statistically significant.
I see. So, but was there some predictability of the STAT3 mutation itself, irrespective of what treatment they received?
Basically, when we combined together in the STAT3 mutational status and also the treatment responses, we could not identify any difference in terms of the response to treatment.
But the ones who did have the STAT3 seem to do better than the ones who did not have.
That is very interesting finding that we identified was patients with STAT3 mutation had better overall survival than patients without STAT3 mutation, and we are trying to identify what what are the different factors associated with this in terms of having better overall survival.
Excellent. And can you hypothesize what might be the pathways? Is it interferon response elements? Is it SOX elements that are probably trying to make this a more indolent process than a very aggressive disease?
It's a very interesting question, as this is being associated with autoimmune conditions and being associated with STAT3 mutation, but not all the patients have STAT3 mutation. And even in this patient cohort, only few patients have very significant disease burden, so that they might end up requiring 4, 5, 6 different types of treatment modalities. Most of the patients are very they don't have significant disease, and they are very benign, and they don't require much treatment. So it is very interesting to look further into the mutational status and identify what are the causes that making them having a better overall survival.
Excellent. Thank you, Srinivas. I think the take-home message is those who have a diagnosis of LGL, at least do a STAT3 mutation, so that you can potentially have a positive prognostic value. Right? Congratulations, Srinivas.
Thank you.
Good work.
Thank you.
Thank you.